Good day, I am Dr. Teke Apalata, a consultant in clinical microbiology, and welcome to our lecture series. Today we are going to discuss the second part of our lectures on streptococcal infections. And in today's presentation, I will mainly cover post-streptococcal complications like glomerulonephritis and rheumatic fever. So let me just share my screen with you. And as I said, that in this part 2 of streptococcal infection series, we will discuss acute post-streptococcal glomerulonephritis and rheumatic fever. Once again, I am Dr. Teke Apalata, a clinical microbiologist. So, just to remind you, if you missed our first lecture on streptococcal infections, we have different species within the genus Streptococca. And what is causing those post-streptococcal complications that we are going to discuss today, all those complications are caused by beta hemolytic group A Streptococca that we call Streptococca pyogenes. Streptococca pyogenes because it is known to cause pharyngitis, and it also causes skin and soft tissue infection. Then following pharyngitis or skin and soft tissue infection, there are complications. And among those complications, we will discuss glomerulonephritis and rheumatic fever. So we have the first complication is what we call acute post-streptococcal glomerulonephritis. And this mainly occurs in children and young adults, with males affected as twice as often as females. So it found in children, it's mainly among males rather than females. And the predominant M proteins, remember when we discussed our first lecture, if you missed our first streptococcal lecture, you can go and check it. And the link is in this YouTube channel. And we say that Streptococca pyogenes has numerous virulent factors. And it also has what we call M proteins. And the M protein is also used for serotyping of these microorganisms. And there are different serotypes that are able to cause skin infections, and we have other serotypes that are involved in throat infection or pharyngitis. So the M protein serotypes that are associated with skin infections and that are able to cause glomerulonephritis as a complications following initial skin infections are serotype 2, 49, 42, 56, 57, and 60. And the other serotypes like 1, 4, 12, and 25 are actually associated with throat infections and glomerulonephritis. So post-streptococcal glomerulonephritis can happen following either a skin infection or a pharyngitis. And there are different serotypes of streptococca that are involved. Now, there are different pathogenic mechanisms that have been proposed. The first one is that glomerulonephritis might be the result of immune complex deposition. So actually you have a complex antibody antigen that will go and deposit into the kidney and cause glomerulonephritis. The other hypothesis is that it happened as a reaction of antibodies that cross-reactive with streptococcal or glomerular antigens. Or it is an alteration of glomerular tissue by streptococcal products, by streptococcal virulent factors like proteinase or streptokinase. Or it is a direct complement activation by streptococcal component that is deposited in the glomeruli. So those are several mechanisms that have been suggested to explain post-streptococcal glomerulonephritis. But how is the diagnosis made? First, the latent period is of 1 to 4 weeks, but it's in average 10 days between the initial streptococcal infection, whether it's a skin infection or it's a throat infection, but the period between the initial infection and the development of glomerulonephritis, it's in average 10 days, but it can range between 1 to 4 weeks. And anti-streptococcal antibody titers, mainly for anti-DNase B or anti-hyaluronidase, are found to be elevated. But in glomerulonephritis, following a skin infection, the latency period can be much more longer. It can be between 3 to 6 weeks, and usually the anti-streptolizing titers are very low. After a throat infection, however, the latency period is very short. It will be between 1 to 2 weeks, and usually the anti-streptolizing titers are very high. So if the incubation period between the initial infection and the complication is short, usually 1 to 2 weeks, and the antibodies, anti-streptolizing, are elevated, it's usually a complication following pharyngitis. But if the latency period is very high, 3 to 6 weeks, and the antibody, anti-streptolizing titers are very low, it's usually, the complication follows a skin infection. So post-streptococcal acute glomerulonephritis include edema, so the patient will present with edema, hypertension, hematuria, and the urinary sediment abnormalities can be observed, and there is a decreased serum complement level with a little fever or maybe low-grade fever can be observed among those patients. And the long-term prophylaxis with penicillin in this patient following a post-streptococcal acute glomerulonephritis attack is not recommended. It's not the same like we do in a post-streptococcal rheumatic fever, where we put those patients on long-term prophylaxis with penicillin to try to prevent recurrence. So here, penicillin is not recommended following the initial attack. Now, the second complication is what we call rheumatic fever. Now, rheumatic fever, post-streptococcal rheumatic fever, is an autoimmune. It's an autoimmune disease in nature, and it's most likely result in parts from the production of autoreactive antibodies and T cells that are shown to cross-react with some component of the group A streptococcus and the host tissue. So it's what leads to the condition that we see. So it is one of the major causes of acquired disease, heart disease in children worldwide, and with the disease occurring most frequently in underdeveloped countries. So it is much more frequent cause of heart problem in children. And rheumatic fever usually parallels the occurrence of throat streptococcal infection. So post-streptococcal rheumatic fever, it's mainly coming following pharyngitis. It's not like glomerulonephritis that can come after pharyngitis or skin infection, but rheumatic fever, it's mainly found after the patient has developed streptococcal pharyngitis. And usually there is an elevated anti-streptococcal antibodies that accompany rheumatic fever, such as the rise in anti-streptolizing O and anti-DNase B antibody titers. And the latency period, it's usually between 1 to 5 weeks following a throat infection. Now, how do we diagnose rheumatic fever? We use what we call the Jones criteria. So we have major criteria that are 5: carditis, arthritis, chorea, and subcutaneous nodule, and what we call erythema marginatum. So those are major criteria, and we have minor criteria like fever, arthralgia, elevated sedimentation rate, or C-reactive protein, and elevated PR interval when you do ECG. So to make the diagnosis, you need two major criteria. If you have two major criteria alone, you can make the diagnosis of rheumatic fever. Or if you have one major and two minor criteria, you can make the diagnosis of rheumatic fever. Now, when you have an elevated anti-streptolizine titer and an elevated anti-DNase B titer, or a positive throat culture for group A streptococcal, those are just supportive evidence of a complication that is following a group A streptococcal infection. But really, criteria for making the diagnosis are what we call Jones criteria. Now, how do we treat rheumatic fever? We use antibiotics. So after the first episode or attack, we can then put those patients on long-term treatment, mainly to prevent reoccurrence of the condition. And we also use painkillers with or without steroid injections. We use mainly aspirin are used among those children. We use anticonvulsant medication, especially if chorea is more severe. Remember, among the major criteria, we have chorea, that is an involuntary movement. Those are involuntary movements that a patient can present with. And we also recommend bed rest. So there is a subset of rheumatic fever. There are some patients who really don't meet the definition of rheumatic fever. And they might have some of the Jones criteria, but not meeting the criteria for rheumatic fever. So we make a diagnosis of what we call streptococcal reactive arthritis. So sometimes they just develop arthritis without any other Jones criteria. So then it's only called streptococcal reactive arthritis. So streptococcal reactive arthritis is a non-purulent arthritis which occurs following group A streptococcal infection, but it does not fit the Jones criteria for the diagnosis of rheumatic fever. And the arthritis is prolonged in streptococcal reactive for several weeks or months. And the treatment of streptococcal reactive arthritis with aspirin or salicylate is not very effective, like we use aspirin or other salicylate to treat patients with rheumatic fever. So unlike rheumatic fever, which is usually treated with a high dose aspirin, so it does not work in patients with a streptococcal reactive arthritis. So how do we try to do the identification of the microorganism of this group A streptococcal? You can do throat culture. It might be present or not during complications, but if it's there, then you can do the grouping. We use what we call the Lansfield grouping. It's a method that was developed by Rebecca Lansfield. So that can tell you to confirm whether it's a group A pathogen, beta hemolytic group A. And we do mainly serological diagnostic tests like anti-streptolizine O, anti-DNase B, and the other diagnostic antibodies that we have spoken about. Thank you. So this was the second part of our lecture series on streptococcal infections. And in this second part, we mainly focus on post-streptococcal complications, mainly acute post-streptococcal glomerulonephritis and rheumatic fever. So continue to follow our third part that we'll discuss mainly neonatal sepsis that is caused by group B streptococcal. Thank you. Goodbye.